Alterations in mobility, orthopedic treatment. A cast is a rigid mold that immobilizes an injured structure when a fracture does not require surgical reduction or manual manipulation. Types of casts include a cylinder cast, which will leave the fingers or toes exposed, a body cast, which is a cylinder cast, but it encircles the trunk. A hip spica cast will surround one or both legs and the trunk with openings for the anal and genital areas. And realize that casts can be strengthened by a bar going across them. The picture in your book shows the hip spica cast, but it can also be done basically with any type of cast. Cast composition are made out of fiberglass or plaster of Paris. Plaster of Paris is going to provide a better fit, whereas the fiberglass is a lot lighter and allows the skin to breathe. Plaster of Paris, there's also a risk of skin impairment. The cast is going to align and support the fractured area, and once they get that alignment in the appropriate place, then they'll apply the casting materials. The cast material itself will feel warm during application, and it does take a while for it to dry, and we should support the drying cast on pillows, being careful not to put unusual pressure anywhere until the cast material is dry. Cast windows can be cut into basically any cast to permit direct inspection of an area under the window, and then the window would be replaced and secured. We do this when the client reports any discomfort or if there's a wound that requires a regular dressing change. A bivalve cast can either be made of plaster of Paris or fiberglass, but it's a cast that's cut in half, and we do that when a client has a swollen arm or limb and we need to expand the room for the tissue to swell. When a client is being weaned from a cast, when a sharp x-ray is required, or if it's being used as a splint. Cast removal will be done with a mechanical cast cutter. It does not cut the skin, although when you look at it, it looks like it would. The skin, once the cast is removed, usually appears mottled and can have a crust on it from dried, dead skin cells. And the muscle also looks atrophied. The nurses can apply lotion and warm soaks to help remove that crust and provide reassurance that that muscle will beef back up once they begin to exercise it again. So true or false? When a limb is placed in a cast, the joint is set straight to assure bone alignment. This is false. The cast would be applied from the joint above the break to the joint below the break, and that joint would be flexed a little bit to help decrease the possibility of joint stiffness. Splints are going to immobilize and support an injured body part in a functional position. They can be made of plaster or a pliable thermoplastic material. All splints should be padded. Then they are going to be secured maybe with an elastic bandage or Velcro straps. Braces are also going to provide support, but they help control movement and prevent additional injury. Clients and family need to receive appropriate education on their use, and braces are usually made of plastic, canvas, leather, or metal, and they're often custom fit to the client. So, true or false? Braces provide support, control movement, and prevent further injury. This is true. So when we're reducing fractures, this means that we're restoring the proper alignment to the bone. The method will be dependent on the first aid that was provided, location and severity of the fracture, and the age and overall condition of the client. Of course, there's always cast application that can help with fracture reduction. We can also use traction, which will pull structures of the musculoskeletal system, and it involves a countertraction. If you look at the picture of the Bucks traction on the slide, you can see that the client's body weight is providing the countertraction to the weight that is being pulled on the boot that is attached to the client's leg. Traction can help relieve muscle spasms, align bones, and help maintain immobilization. Types will include skin, which involves that device to the skin, such as a boot and in the picture, and skeletal traction, which involves pins or wires that have been placed in the bone. To assure proper alignment, the nurse needs to make certain that the weights are hanging freely. In other words, they're not sitting on the floor or have gotten tangled up in the bed trapeze, etc. And the nurse needs to monitor for skin impairment. Closed reduction will require external manipulation of the bone prior to immobilization. Open reduction would be the surgical exposure and realignment of the bone, while internal fixation is a surgical procedure that's used to reduce and stabilize the fracture with plates, screws, rods, nails, or pins prior to immobilization. We use this type of procedure with significant soft tissue injury, wide bone separation, comminuted fractures, patella or other joints are fractured, open fractures, or if wound debridement is required. External fixation will involve the insertion of metal pins in the bones from the outside skin surface. Then it attaches an external metal device to stabilize, position, and immobilize the bone. And nurses, it's very important to monitor the pin sites for infection. And there's a great picture of an external fixator in your textbook. Orthopedic surgery is done to correct a deformity, remove a primary bone tumor, align fractured bones, repair or replace a joint, insert bone grafts, and stabilize a bone internally. An open reduction internal fixation, commonly referred to as an ORIF, frequently prior to the surgery, the client will have a Bucks traction applied if surgery cannot be done immediately, but the surgeon will commonly use nails, an intermedullary rod which goes into the bone itself, a plate, or wires. And it's going to hold the bone fragments in place until bone healing has been completed. For joint dysfunction correction, we often will do an arthroplasty, which is reconstruction, and that usually happens to the knee or the hip, or an arthrodesis. We can also do an osteotomy or a hemoarthroplasty, a total arthroplasty. And postoperative complications would include hemorrhage, dislocation of that artificial joint, pictures of which are shown above, infection, thromboembolism, and avascular necrosis. Preoperatively, the nurse needs to obtain a complete history and assess for any complications from previous treatments, assist in reducing pain, the risk of infection, and increasing mobility, and helping control anxiety and help the client understand instructions. Postoperatively, we need to make sure that we have provided the appropriate post-op routine demonstrations such as your turn, cough, deep breathe. We need to explain any post-surgery devices and reduce the risk for excessive bleeding. Of course, review the physician's orders and potentially place the CPM devices and making sure that the client is getting appropriate flexion. The CPM device is going to be applied to a client's leg, for example, after they've had knee surgery, and this actually forces the client's knee to bend or flex. Nurses should also need to help with pain reduction and inflammation and prevention of any postoperative complications. Client and family teaching is going to require a support system post-discharge and exploring the kind of assistance that might be needed by the client. They may need some modifications in their home environment or information about home care. They may also require an in-facility rehabilitation prior to going home. We may need to help them get a referral to a home health care agency. We should always provide the printed discharge instructions to include their activity, physical therapy, and symptoms to report. There are certain precautions with the hip and the knee surgery that are important for nurses to make sure they follow and then pass on to their clients. With the hip replacement, most of the time the legs will need to be abducted with pillows or an abductor cushion, such as the one pictured in your slide, and they need to be extended because the opposite positions of adduction and flexion beyond 90 degrees can dislocate that prosthetic femoral head from the acetabulum. We also need to encourage the client to sit in a chair or on a seat that's been raised by pillows so that flexion remains less than 90 degrees. With knee replacement, clients that have the knee replacements need to know the amount of flexion and frequency of the devices that are going to be used while they're being hospitalized to help improve their flexion. The goal is for the client to have the ability to bend the knee 90 degrees by discharge. And the amount of flexion for clients with hip replacements should never exceed 30 degrees in a CPM machine. And clients that have had knee replacements or hip replacements should be instructed to never cross their knees. Amputation is the removal of a limb due to trauma or to control disease or disability. Amputations can be done because of malignant tumors, long-standing infections, extensive trauma, tissue death, thermal injuries, limb deformity, or life-threatening disorders. The limb or tissue will be removed to the level where there's healthy tissue and a blood supply. In other words, we don't want to take more tissue than necessary. And we also want it to be to an area that's going to promote the fitting of prostheses. The description of the amputation is going to be at the level in which the limb is amputated. In other words, a BKA is going to be below the knee amputation. An AKA is going to be above the knee amputation, etc. Amputation methods are going to involve the open method, also known as the guillotine method, the closed method, in which there is a flap of skin that's used to cover the severed end, and a staged method, which initially is open and then later will be closed. Postoperatively, these clients often require a compression sleeve, wrap, or plastic shell that's placed over the stump to help reduce bleeding and edema. The client can be fitted with a prosthesis after that surgical wound has completely healed and there's no longer a risk of potential damage to the wound. Complications of amputations include a hematoma, hemorrhage, infection, stump neuroma, and this is where the nerve ends will become tangled in the scar tissue. Some clients with an amputation will experience a phantom limb sensation, and that's the feeling that the limb is still there. Some clients will experience phantom pain, which is pain that's felt in the limb that's no longer there. And it can affect the client's ability to use a prosthesis and may require removal of nerves at the end of the stump. We should always treat phantom pain as real pain. If they complain of pain in a missing foot, then we ask them what their pain level is and we medicate them appropriately. Nursing management pre and postoperatively include monitoring of the diseased, injured limb or stump for circulation, pain. We need to make sure we're elevating application of that compression stocking or wrap. Client needs to be educated on surgical expectations. Nurses need to provide emotional and spiritual support and appropriate wound care. It is also important for nurses to be familiar with how to teach clients to use crutches. Although physical therapy usually deals with this, we need to be able to reinforce what physical therapy is teaching. So by the time of discharge from the hospital, a client with a knee replacement should bend the knee how many degrees? 90 degrees.